Good afternoon, everyone. Thank you for having me again. I hope you find this helpful. And as you know, non-ischemic cardiomyopathy is a really vast, topic in and itself. And so I'm really going to focus on aspects that are unique to non-ischemic cardiomyopathy. So those will be pertaining to evaluation and causes of non-ischemic cardiomyopathy. So this is, this is something that all of you must be familiar with. This is the ASCC-AHA classification for heart failure. And this is really key to understand because it helps us in early detection as well as initiating therapy even prior to obvious signs of cardiac dysfunction. And so this is really key for our patients. Stage A heart failure is patients who are at risk of heart failure but don't have any structural heart disease or symptoms of heart failure. So these are patients with hypertension, for instance, atherosclerotic disease, diabetes, obesity, or patients who have a history of using cardiotoxins or family history of heart failure. Stage B heart failure is when you have structural heart disease, but without any signs or symptoms of heart failure. So these are patients who've had an MI or LVH, low EF, essentially LV remodeling or asymptomatic valvular disease. Then stage C is when you have prior or current symptoms of heart failure. So this is when we start instituting our neurohormonal therapy for heart failure, consider devices, etc. Stage D is when you have refractory symptoms despite goal-directed medical therapy, and these are really the patients you should have goals of care discussion with, consider palliative therapy if those are their wishes, or advanced heart failure therapies like MCS or heart transplantation. So with that introduction, let's get started. First, we're going to go over the definition, then pathophysiology, clinical features, etiology and evaluation, and then therapy. And I'm really going to focus on the pathophysiology and etiology and evaluation because that's something that's unique for non-ischemic cardiomyopathy. The general features of cardiomyopathy, as well as the therapy for cardiomyopathy, is essentially pretty standard regardless of the etiology. Unfortunately, we haven't reached that stage of individualized medicine yet where we can really tailor our therapy based on the etiology of cardiomyopathy, but there's ongoing research in that area, and as data continues to accrue, we have better approaches, at least for individualizing diagnosis as well as prognostication. And for therapy, we are hopefully getting there. So cardiomyopathy overall, as you know, is a heterogeneous group of diseases of the myocardium that's associated with mechanical and or electrical dysfunction. That's usually, but not always, associated with inappropriate ventricular hypertrophy or dilatation, and it's due to various etiologies, frequently genetic. It can be confined to the heart, or it can be a generalized systemic disorder, often leads to CV death or progressive heart failure related disabilities. So the broad categories of cardiomyopathies are really hypertrophic cardiomyopathy, dilated, restrictive, and a smaller component of arrhythmogenic or unclassified cardiomyopathies. And any of these can be familial or genetic. So these are the main categories where you have normal, this is a normal heart up here, dilated cardiomyopathy that is distinctly known by its dilated phenotype, hypertrophic cardiomyopathy, and then restrictive cardiomyopathy. Today, we're going to focus on dilated cardiomyopathies. So dilated cardiomyopathy is essentially LV dilatation and systolic dysfunction in the absence of coronary artery disease or abnormal loading conditions proportionate to the degree of LV impairment, such as hypertrophic cardiomyopathy or valvular cardiomyopathies. So even though ischemic cardiomyopathy and valvular cardiomyopathies have a dilated phenotype, typically when you're talking about dilated cardiomyopathy, you mean an idiopathic cardiomyopathy in the absence of ischemic heart disease or valvular heart disease, hypertrophic cardiomyopathy, etc. So we're not going to talk about ischemic cardiomyopathy today because the management for that is quite distinct. It predominantly affects younger adults. It's the most frequent indication for heart transplantation. And dilated cardiomyopathy in and of itself is not a single disease entity, but it's rather a non-specific phenotype, and it's the final common response of the myocardium to a number of genetic or environmental insults. Going to the pathogenesis, The first step is really myocyte injury, and that can be from a number of different things, which we'll talk about in a little while when we talk about specific etiologies. And typically, what is being investigated now, and what we've really learned, is something called a two-hit hypothesis. That means a lot of times it isn't just one factor that's causing the myocyte injury. It's a number of different factors that are coalescing and really cause myocyte injury. And the more risk factors you have, the more your risk is. This can lead to immediate myocyte cell death, delayed myocyte cell death by apoptosis, and then a pathologic compensatory response from the remaining myocytes. And this is really what leads to the pathophysiological changes that lead to a dilated cardiomyopathy. So with myocyte injury, the compensatory response of the remaining myocytes is hypertrophy. And that is because there's less myocytes to essentially, there's less myocytes left because of the cell death of the remaining myocytes, the less myocytes left. So there's increased wall stress because the amount of work that has to be done by less myocytes. So there's increased wall stress, and in response to that wall stress, there's hypertrophy of the remaining myocytes because that's their compensatory mechanism. There's also an hyperadrenergic response. These together lead to, and in addition, there's dynamic remodeling of interstitial myocardial skeleton, and this includes fibrosis. The LV dilatation and remodeling leads to distortion of the valvular apparatus, leads to elevated afterload, and that's what essentially leads to the beginning stages of congestive heart failure. So those were the changes that we see at a cellular and tissue level. At an organ level, this is what we see: LV dilatation, remodeling, and then the LV becomes progressively more spherical. This leads to a decrease in the stroke volume, decrease in the cardiac output, reduction in ventricular compliance due to hypertrophy or fibrosis. These together lead to impaired ventricular filling, which increases the end diastolic pressure. In addition, there are compensatory changes in the vascular system, and these are also driven by the hyperadrenergic state. These changes involve increase in SVR, decrease in arterial compliance. This leads to an increase in the venous pressure and an increase in the circulating blood volume. So as I talked about in these first couple of lines, because of these factors, there's increase in the afterload and increase in the preload. Increase in the afterload is, as we mentioned over here, because of the increased SVR, decreased arterial compliance, and increased preload because of the increased venous pressure and increased circulating blood volume. These together also further increase wall stress. And over time, this leads to diastolic dysfunction as well as systolic dysfunction. In addition, there are secondary neurohormonal changes. These are increased sympathetic adrenergic activity and decreased vagal activity to the heart. This is a result of increased circulating catecholamines, increased vasopressin, stimulation of the renin-angiotensin-aldosterone system, and increased circulating natriuretic peptides. These together lead to increase in afterload, fluid retention, and tachycardia, which further increases wall stress and myocardial oxygen demand, and also causes direct cardiotoxicity. So these secondary adaptations, though they're meant to be compensatory, over time lead to myocyte damage and a further reduction in myocardial performance. Compensatory hypertrophy is, essentially initially it's supposed to be positive. It allows for more muscle fibers to share in wall tension for any given ventricular pressure and radius. But over time, this starts to have a negative or maladaptive effect. So putting everything together, what we discussed was the hemodynamic and neurohormonal model for development of dilated cardiomyopathy. The key features that we discussed was that because of myocardial injury, there is decrease in the cardiac function. Initially, these responses are adaptive, and those are activation of the sympathetic system, renin-angiotensin system, and other inflammatory pathways, hypertrophy, remodeling, and apoptosis. Over time, these adaptive responses become maladaptive and lead to dilatation of the chambers, hypertrophy, increased wall stress, and increased oxygen demand. The next model for the implicated in the pathophysiology of dilated cardiomyopathy is the abnormal calcium cycling model. Calcium, as you know, is a very important ion for myocardial function and myocardial contractility. This is very complicated, but essentially, the main steps that you should know is that myocardial contraction is initiated by entry of calcium into the cells, into the myocytes. Calcium enters through these L-type calcium channels. This calcium is then taken up by the sarcoplasmic reticulum, where it causes contraction of the actin myosin fibers. And then at the end of contraction, this calcium is released, taken up by the SERCA2 receptors through the ryanodine receptors and through the calcium sodium exchangers, is pumped out of the myocardium. Some of the key, we're still learning a lot about what changes exactly in calcium cycling lead to the development of dilated cardiomyopathy, but some of the key changes that have been identified are these. The first is the diastolic leak of calcium through altered ryanodine receptors. This lowers the calcium content of the sarcoplasmic reticulum, reducing the amount of calcium that can be released during activation, and so it weakens contraction. The other important change that's been identified is loss of function of the SERCA2 pump, which reduces the amount of calcium content in the sarcoplasmic reticulum. And so, so less calcium can be released during myocyte activation, causing systolic dysfunction and ventricular arrhythmias. We still don't really know why these changes happen. It's thought that these can be as a result of genetic predispositions, genetic mutations, or injury by various toxins. Other models that are important in the development of dilated cardiomyopathy is the cell death model, which is as a result of abnormal elevations in circulating neurohormones, excessive adrenergic activity, like we talked about earlier, as well as direct cell death from inflammation, oxidative stress, and toxins like alcohol, cancer, chemotherapeutic agents, and infiltrative processes. Genetic models are also increasingly being studied and thought to be increasingly relevant. We'll go over this later in genetic cardiomyopathies, but various genetic mutations involving sarcomeric proteins, genes that encode for proteins responsible for contraction, cell survival, nuclear envelope proteins, desmosomal proteins, as well as microRNAs have been identified. And it is thought that the pathophysiology isn't just one of these models, but rather a complex interplay of all of these mechanisms put together that lead to the development of dilated cardiomyopathies. So at a gross tissue level, organ level, these are the changes that you see in dilated cardiomyopathy. Here on the right is a normal heart. This is a cross-section of the heart. So you're seeing the LV like a donut, the RV on the side. And this is a cross-section of a dilated cardiomyopathy. And you can see how dilated the LV and RV are and how thinned out they are. And you can see increased fibrosis as well, particularly in the septum and RV insertion sites over here. Another just gross specimen just showing how the LV has become so spherical. There's a lot of white that you're seeing over here. That's all fibrosis, which is abnormal. This is a histopathological specimen of dilated cardiomyopathy. Again, biopsy is not something that's frequently done. And some of the features are really quite non-specific for dilated cardiomyopathies. We'll go over some of this. We'll go over certain indications where biopsy may be useful. This over here on the top left is a normal myocardium under microscopy. You can see how the myofibers are nicely arranged, and there's no fibrosis at all that is visible over here. Here on the right, you can see there's myofibril disarray. There is loss of myocytes, destruction of myocytes, increased vacuolization, and there is myocyte hypertrophy. Notice how much thicker these are compared to the normal myocytes. This is another specimen showing a lot of myofibril disarray, destruction of myocytes, hypertrophy, and a lot of fibrosis also. This is a trichrome stain showing a lot of fibrosis in the myocardium. Coming to epidemiology, the prevalence of dilated cardiomyopathy is thought to be about 36 cases per 100,000 or 1 in 2,500. And the prevalence of dilated cardiomyopathy varies in different countries. And obviously these are from registry studies. So these incidences may be underreported as well. In multi-center randomized trials for heart failure, about 30 to 40% of enrolled patients have non-ischemic cardiomyopathy. And according to the DEAR registry, which is a registry of acute decompensated heart failure patients who are admitted to the hospital, about half the patients are admitted with a diagnosis of non-ischemic cardiomyopathy. This can occur at any age, most commonly in the third or fourth decade of life. The advancing age is an independent risk factor for mortality in dilated cardiomyopathy. Prognosis has significantly improved as well. However, there are disparities in the prognosis. Compared with white patients, Blacks have an almost 3 times risk in developing cardiomyopathy, which is not just explained by confounding variables of hypertension or social or economic factors. Blacks also and minorities have worse prognosis also, which again is not just explained by social or economic factors, but those two play a big role in the disparity. Most of the natural history studies are really from before the time of guideline-directed medical therapy. So this has evolved over the last several years as well with the innovations in diagnostic techniques as well as management. So the natural history is really not quite well established. About 25% of patients with dilated cardiomyopathy have with recent onset of symptoms will have spontaneous improvement. If symptoms have been present for more than 3 months or so, and their presentation was with severe clinical decompensation, generally there's less chance of recovery. But again, this is changing now with the advent of our newer medical therapy. 1 year mortality is about 25 to 30%. Again, this doesn't necessarily reflect the implementation of all the goal-directed medical therapies that we have now. 5-year prognosis is 50%. The worst prognosis is associated with an EF of less than 25%, RV involvement, poor NYHA functional class, poor hemodynamics, and advanced diastolic dysfunction and pulmonary hypertension. And I'm talking about group 2 pulmonary hypertension or mixed pulmonary hypertension over here. Cause of death is pump failure in about 2/3 of the patients and sudden cardiac death in 1/3 of the patients. This is also why in patients who have stage D heart failure, if they're not candidates for advanced therapies, implanting an ICD is not recommended because they're more likely to die from pump failure than from sudden cardiac death. And sudden cardiac death is caused by electromechanical dissociation or ventricular arrhythmias, occurs in about 1/3 of the patients. Clinical features. Again, I'm not going to go into much detail because I'm sure you're all familiar with symptoms of heart failure. These are not different for non-ischemic cardiomyopathy compared to other forms of cardiomyopathy. Most patients will present with symptoms of heart failure, and those are effort intolerance, dyspnea with exertion or dyspnea with rest. In more advanced cases, edema, orthopnea, bendopnea, paroxysmal nocturnal dyspnea, and weight gain. Palpitations and syncope can also occur. Syncope can be related to arrhythmias or because of decreased cardiac output, and is a bad prognostic sign if it's related to decreased cardiac output. Can also be related to medications. Abdominal discomfort, nausea, anorexia, and cachexia can be prominent in advanced cases, and when you're seeing these, again, these are bad prognostic signs. Cognitive decline can also occur over time with low cardiac output in advanced cases. And the most severe manifestation of heart failure is circulatory collapse and cardiogenic shock. Rarely, thromboembolic events can occur in patients with severely reduced ejection fraction that can be related to an LV thrombus or atrial fibrillation and a left atrial appendage thrombus. Rarely, sudden death can also be the initial symptom. These are examination findings in patients with heart failure, which you're all familiar with. Left-sided heart failure signs are really pulmonary edema, cardiomegaly. Important things that you want to note on the examination is if the patients are tachycardic, if they have a regular or irregular pulse, a narrow pulse pressure, which is the difference between the systolic and diastolic, pressure, and this should be 1/3 of the systolic. If it is less than 25% of the systolic, that's considered a narrow pulse pressure and is a bad sign, is reflecting a very low cardiac output. You can hear murmurs, most commonly murmurs of mitral regurgitation or tricuspid regurgitation, and S3 because of the increase in diastolic volume, or gallop as well, which is both an S3 and an S4. S4 is from increase in diastolic pressure or an advanced diastolic dysfunction. Point of maximal impulse that is laterally displaced because of LV enlargement. So the apex is laterally displaced. Instead of being in the mid-clavicular line, it's going to be in the anterior axillary line. Features of right-sided heart failure are elevated JVP, hepatojugular reflux, hepatomegaly, ascites, pleural effusions, and peripheral edema. And most commonly, you'll see signs of both left and right-sided heart failure. In certain cases, if it's an RV predominant cardiomyopathy, then you'll see more right-sided heart failure signs. Signs that you'll see in more advanced cases are a low BMI, temporal wasting, and really impaired mobility. This is the Lynn-Warner-Stephen classification of heart failure, and really something you should keep in mind when you're examining patients. You should really try to profile them based on this into whether they're dry and warm, wet and warm, dry and cold, or wet and cold. The dry and cold represents their perfusion status, whether they have a normal cardiac output or a low cardiac output. Signs of poor perfusion are cool extremities, low urine output, altered mental status, inadequate response to IV diuretics, and prerenal azotemia. Signs of congestion, as we discussed earlier, are JVT, edema, S3, symptoms of orthopnea, dyspnea and exertion, recent weight gain, etc. And this is important because in addition to helping you with in addition to helping you with treatment, it is also prognostic. The best is dry and warm. This is where you want to get your patients, and the worst profile is dry and cold. So history and physical examination, these are the guideline recommendations for what your history and physical examination should encompass. And essentially this should be geared towards identifying cardiac and non-cardiac disorders or behaviors that might cause or accelerate the development or progression of heart failure. In patients with idiopathic dilated cardiomyopathy, a 3-generational family history should be obtained. And volume status and vital signs should be assessed at each patient encounter. This includes serial assessment of weights, estimates of JVP, presence of edema or orthopnea. ECG findings can vary a lot in dilated cardiomyopathy. You want to see if there's tachycardia, if they're in sinus rhythm or arrhythmias. You can see evidence of LVH in certain patients. You might see abnormalities in conduction, like a prolonged PR interval, wide QRS, left bundle morphology. Particularly in patients with Lamb cardiomyopathy, you can see heart blocks. You want to see if there's a lot of PVCs or ventricular arrhythmias. You can see VT also in these patients. So really the ECG features can vary a lot. You might see changes in repolarization, prolonged QT as well. Chest X-ray findings. Again, if patients are decompensated, volume overloaded, you'll see pleural effusion, cephalization of the vessels, enlarged pulmonary artery, cardiomegaly, and curly B lines. Echo features. Echo is really key for diagnosis as well as serial assessment and assessment of prognosis response to therapy as well. I apologize, the image didn't show up. But what you'll see in dilated cardiomyopathy is LV dilatation, decreased systolic dysfunction. You want to assess the RV pressure, the RV size and function, assess the valves as well, see if there's MR or TR. You can assess the stroke volume as well on echocardiography. You can assess the pulmonary arterial pressure as well. So those are key things that you want to look at on echo. Cardiac MRI can also be really helpful, again, for diagnosis as well as assessment of severity of disease and of assessing certain etiologies as well. So, and these are measurements taken at end diastole and end systole, and this is how ejection fraction is calculated on an MRI. And obviously, you'll see a decreased ejection fraction. Then you also do volumetric analyses of the various chambers. You can see biatrial enlargement or left atrial enlargement as depicted over here. This is a T1 map that is showing edema that can be present in inflammatory cardiomyopathies or infective cardiomyopathies like myocarditis. Here in F, we're seeing late gadolinium enhancement. So gadolinium is an extracellular material, and it is taken up if you have fibrosis in the interstitium. So it represents scar. In non-ischemic dilated cardiomyopathy, you'll see patterns of LGE that are different from ischemic cardiomyopathy. In ischemic cardiomyopathy, the infarcts are going to follow a vascular distribution. So you might see, and it's going to be either subendocardial or transmural, but really it's going to extend from the subendocardium because that's how infarcts go, from the subendocardium to the mid-myocardium to the epicardium. And so, for instance, in an LAD infarct, you might see late gadolinium enhancement in the apex, and then in the mid-anterior, mid-septum, depending on how extensive it is, can go to the basal segments as well. But it's really going to be in a vascular distribution, and it will be subendocardial or transmural. In non-ischemic cardiomyopathies, the pattern can really vary a lot. The classical finding is mid-myocardial enhancement in the septum. Here you're seeing mid-myocardial enhancement in the septum as well as the infralateral wall. Again, here you're seeing mid-myocardial enhancement in the septum. It can become transmural as well. Here again, it's mid-myocardial in the infralateral wall. Even in the absence of frank fibrosis, you can see an increase in the extracellular volume. And this is a T1 map over here, which is showing you the amount of extracellular volume. And yellow is normal and green is abnormal. And you can see in the septum over here, there's a lot more green that's representing an abnormal T1 scale. Another thing that cardiac MRI can be diagnostic for is the detection of iron overload or hemochromatosis. There's something called T2 star, which is abnormal when you have iron overload. So the way that's calculated is by circling various areas of the myocardium, and then it calculates and gives you the T2 star value. And the shorter it is, the more abnormal it is. So more than 40 is normal, less than 40 is abnormal, and less than 20 is associated with the high risk of development of heart failure. Coming to biomarkers now, there are several biomarkers that are used clinically. There are a few biomarkers that are used clinically, and several more that are being investigated but are not yet being used clinically for various reasons. Either the test is, either the biomarker itself is very short-lived and there are difficulties with assays, etc., or they're just very non-specific. Some of the biomarkers that we clinically use are biomarkers of myocardial stretch, which, as you know, are natriuretic peptides. ANP is not used because of its short half-life. What we use clinically is BNP and NT-proBNP, which is the precursor of BNP. Myocyte injury is troponin, which again is a poor prognostic sign, but is not specific for heart failure per se. There are markers of matrix remodeling, like matrix metalloproteinases, that can be elevated in heart failure, but we don't use it clinically. Inflammatory markers like high sensitivity CRP, markers of renal dysfunction like cystatin and kidney injury molecule. These are used more in research studies. And so one of the roles of these renal dysfunction markers, at least in research, is to see in cardiorenal syndrome or with worsening renal function associated with diuretic therapy or with initiation of neurohormonal antagonism, whether the renal dysfunction that's seen is actually associated with tubular atrophy or not. And one of the things that we've learned from studying cystatin C in the ROSE trial, which is a trial of dopamine in acute decompensated heart failure, was really that there's no tubular atrophy that's seen even when there's worsening renal function associated with decongestion. Other markers of neurohormonal activation like adrenomedullin, markers of oxidative stress, as well. Myeloperoxidase, for instance, these are used in research, but not really clinically. BNP is really the most important marker, sorry. Yeah. BNP is really the most important marker, which has a role in diagnosis. There's a level of evidence, there's a class of recommendation 1 for using BNP or NT-proBNP in ambulatory patients with new onset dyspnea and with acute patients who are presenting with acute dyspnea to the ED as well. So this is where you can have a role in diagnosis. It's not really used to guide therapy, as mentioned, as written over here. It's not used to guide therapy. It can be used. It can be used to assess prognosis prior to discharge. That has a class of recommendation 2A. So this is something that I do use in clinical practice is admission BNP or NT-proBNP and a pre-discharge BNP or an NT-proBNP to make sure that you've adequately decongested the patients. And even if it's significantly elevated, you haven't seen a reduction of 50%, then either the patient is not clinically decongested or and that's a bad prognostic sign. Coming to etiologies and diagnostic evaluation, this is really going to be the bulk of our presentation over here. Until recently, the evaluation was a standardized approach, but with advanced imaging techniques together with modern genetic biomarker biopsy analysis, we can now perform a more rigorous assessment of etiology as well as cardiac remodeling and early disease detection as well. Before diagnosing dilated cardiomyopathy, it's necessary to exclude conditions with a phenotypic overlap. Identification of a specific underlying etiology can allow for targeted disease-specific treatment and also guide the need for family screening or informed prognosis. So first, when you present, say you have a patient who's presented with those signs and symptoms that we talked about earlier, and you're thinking that this patient has dilated cardiomyopathy. The first thing you want to do is make sure that you exclude other causes which can have phenotypic presentation that is similar. So other causes that you want to, other etiologies that you want to exclude. The first is ischemic cardiomyopathy. Most patients who are presenting with a new diagnosis of heart failure should have some form of coronary assessment, whether it's invasive or non-invasive. An invasive assessment should be considered in patients who have higher risk of having coronary artery disease, for example, age, smoking, diabetes, hypertension, or other risk factors. And ischemic cardiomyopathy is defined as having cardiomyopathy associated with a more than 75% stenosis in either the left main or the proximal LAD or more than 2 epicardial coronary arteries. In about 10 to 15% of patients who don't have this, and we have noticed on studies that on CMR, cardiac MRI that is, they can still have LGE that is in an ischemic distribution. So it is possible in a small percentage of those patients, even if they don't have significant coronary artery disease based on angiography, that they probably had an MI in the past and then spontaneously decanalized. So an MRI can have additional value as well. And another important cause that can phenotypically appear similar to LV, similar to dilated cardiomyopathy is hypertensive heart disease. And those will have certain features. For example, you see increased LV wall thickness on echocardiography, LVH on echo, and obviously a history of chronic or poorly controlled hypertension. Advanced hypertrophic cardiomyopathy can sometimes appear similar to dilated cardiomyopathy. These are burned out end-stage HOCM patients with a very dilated LV. They may have a long-standing history of hypertrophic cardiomyopathy, increased wall thickness, extensive patchy myocardial fibrosis on LGE, as well as positive genetic testing. ARVC is arrhythmogenic right ventricular cardiomyopathy, very important to distinguish from dilated cardiomyopathy. Sometimes it can be more challenging to distinguish because there are left dominant forms of ARVC as well. And there are, ARVC is classically caused by mutations in the desmosomal proteins. And an MRI can be really helpful in diagnosing ARVC. You'll see disproportionate LV RV remodeling or dysfunction, RV regional wall motion abnormalities, or localized dysynchrony. They can be particular ECG signs, as well associated with ARVC. Myocardial non-compaction is a cause of dilated cardiomyopathy, but again, something you want to distinguish as well, because it is a separate entity on its own. And there are certain key differences in management that are a little bit different from other idiopathic dilated cardiomyopathies. Myocardial non-compaction tends to be overcalled a lot in MRI. It's not just the, so the classification criteria for myocardial non-compaction is based on a ratio of non-compacted to compacted myocardium of more than 2.3 on MRI and more than 2 on echo. It tends to be overcalled a lot because even non-ischemic cardiomyopathy patients, especially African Americans, can have increased trabeculation, but it's important to note that myocardial non-compaction is not just trabeculations. There have to be deep perfused intertrabecular recesses as well. And it has to be present in at least 4 to 6 of the basal segments. Athlete's heart can sometimes phenotypically appear similar to cardiomyopathy as well, but you'll see that these patients otherwise have no signs or symptoms of heart failure. They'll have normal natriuretic peptides, normal ECG, normal diastolic dysfunction, normal strain, and normal, or in fact, a high peak VO2 on CPET testing. One thing that can be done to distinguish athlete's heart, from cardiomyopathy is having the person stop exercising, and then you'll actually see reverse remodeling with deconditioning. Cirrhotic cardiomyopathy can also have certain features like LV dilatation, diastolic dysfunction, but you'll have a history of having chronic liver disease. There are other features of cirrhotic cardiomyopathy also that can be helpful, like bradycardia, prolonged QT interval. So now coming to causes of dilated cardiomyopathy. So the idiopathic is really the most common cause, which essentially means that we don't really know what's causing it. But as we're doing more research, we'll probably find out that more and more of these so-called idiopathics have a genetic basis. So this is why detailed family history is really important, and ECG can be helpful. AV blocks are quite common in lamin associated with cardiomyopathies. And if you see any of these features, you have a young patient with unexplained cardiomyopathy, genetic testing is recommended as well. And neuromuscular disease is a sort of a subset of genetic cardiomyopathies. In genetic cardiomyopathies, we'll discuss this in the next slide really, but there are several neuromuscular diseases that are associated with cardiomyopathies. So 35% of idiopathic cardiomyopathies have a genetic basis. Most of these are autosomal dominant. There are some that can be autosomal recessive or X-linked. Predominantly the muscular dystrophies are autosomal recessive and X-linked. LV non-compaction typically is autosomal dominant or X-linked. There's a syndrome called Barth syndrome, which is characterized by severe non-compaction cardiomyopathy, often diagnosed in childhood. And then other genes that are associated with LV non-compaction are sarcomeric proteins, that is the myosin heavy light chain and the myosin binding protein. Other genes that are associated with genetic cardiomyopathies are genes that encode the sarcomere, cytoskeleton, nuclear envelope, transcriptional pathways, and mitochondrial proteins. These are some of the important genes associated with cardiomyopathy. The most common that you should probably know are titin and lamin. Titin is responsible for about 20 to 25% of familial dilated cardiomyopathy, and lamin AC is associated with 5% of dilated cardiomyopathies. Both of these are autosomal dominant. The way these genetic cardiomyopathies cause cardiomyopathies by causing an alteration in the first generation in transmission because of these abnormal proteins. Typically, these are proteins that are involved in the sarcomere or cytoskeleton, altered metabolic profiles, disruption of energy production and consumption, abnormal nuclear integrity, transcriptional dysregulation, altered protein degradation, and ion channel abnormalities, mainly calcium homeostasis and abnormal calcium handling, like we talked about earlier. So clinical and genetic testing in families is recommended if there is a history. Now there's commercially available genetic testing for DCM. Panel consists of about 20 to 50 genes. The yield is about 15% to 40%, depending on patient selection and family history. So basic evaluation should consist of detailed family history spanning a minimum of 3 generations and initial clinical screening of first-degree relatives as well. This should include an ECG and an echo as first line, and in certain cases, exercise testing, 24-hour ECG monitoring, or cardiac MRI can be considered. Families in which pathogenic gene mutation is identified, cascade genetic testing in at-risk relatives is recommended, along with pre and post-testing counseling. If the tested individuals do not carry the pathogenic gene mutation, you don't need to survey them lifelong. If they do carry a mutation, then they should be monitored at regular intervals, and any available prevention strategies should be initiated, and that's predominantly primordial prevention, so management of hypertension, blood pressure, hypertension, diabetes, weight, etc., smoking. In the absence of any identified pathogenic mutation, first-degree relatives should have periodic ECG and echo as well. And the frequency should be individualized depending on the family history and the age of onset in affected family members. Generally, you want to screen relatives about 1 to 2 years up to the age of 20, and after that, every 2 to 3 years. And then once they're older, then every 3 to 5 years or so. The next important cause of dilated cardiomyopathy are toxins. Alcohol is probably the most common that we come across in clinical practice. Most common in men 30 to 55 years of age who have been heavy consumers of alcohol for more than 10 years or so. So it's important to note that mild or moderate alcohol use is typically not associated with alcoholic cardiomyopathy. It has to be really significant alcohol consumption. Women represent a smaller percentage of alcoholic cardiomyopathy cases, but they may be more vulnerable because women do develop it with a total lower lifetime exposure to alcohol than men. Alcohol in the acute setting as well as chronically depresses myocardial contractility and is a direct myocardial toxin. There can be genetic predisposition or presence of other factors like hypertension, nutrition deficiencies, and arrhythmias that can play a role in the development of alcoholic cardiomyopathy. The general management for this is essentially similar to any other heart failure, and total abstinence from alcohol in addition to conventional management for heart failure is recommended. Coming to the next set of toxins that are increasingly becoming more important and significant and important to recognize early on are chemotherapeutic agents. This is especially important because this type of cardiomyopathy is actually preventable and reversible if detected early on. The most important agents that we should remember are anthracyclines, HER2 receptor antagonists, but others that can be associated with cardiac dysfunction are immune checkpoint inhibitors, radiation alkylating agents, antimetabolites, antimicrotubular agents, and small molecule tyrosine kinase inhibitor agents. The prevalence of heart failure with the use of these therapies is shown over here. With anthracyclines, the range of depressed ejection fraction varies anywhere between 20 to 40%, and of clinical heart failure is about 5%. The incidence with trastuzumab, which is a HER2 receptor antagonist, is about 2 to 27% for low EF and associated with about 4% heart failure, and the rest are shown over here. This is the mechanism for anthracycline-induced cardiotoxicity, and it's really complicated, but the two basic mechanisms are the reactive oxygen species hypothesis and the topo-2 isomerase inhibition. So reactive oxygen species hypothesis is that the quinine moiety of anthracyclines produces reactive oxygen species, which leads to DNA damage, protein carbonylation, lipid peroxidation, and these lead to cell death and cell dysfunction. Topo-2 isomerase inhibition is another mechanism for development of heart failure. What topo-2 isomerase does is essentially leads to This essentially helps with DNA replication. So inhibition causes double-stranded DNA breaks and leads to mitochondrial dysfunction, mitochondrial biogenesis, and cell death. This is a histopathology of anthracycline cardiotoxicity, of anthracycline-associated cardiomyopathy, and you're seeing myocyte damage, myocyte hypertrophy. There's vacuolization that we're seeing over here. That's a pathognomonic feature of anthracycline cardiomyopathy, this vacuolization, and then fibrosis. It's important to remember that the incidence of heart failure increases with increasing doses of anthracyclines and is different for different types of anthracyclines. The highest incidence is with doxorubicin or adriamycin. And you can see as the dose increases, the incidence of heart failure really shoots up with an inflection point around 300 milligram per meter square, which is why 250 milligram per meter square is considered the cutoff for testing. These are the screening guidelines for development of for anthracycline cardiotoxicity. It's recommended that you obtain baseline assessment of EF, 3D echo is preferred, or 2D echo with contrast, along with strain measurement and troponin I measurement at baseline. And if these are abnormal at baseline, then you want to consider cardiology. If these are normal, then they recommend doing another follow-up at completion of therapy and 6 months later. They also recommend for doses of more than 250 and echo before each additional 50. Trastuzumab is another agent that's very important and has a higher incidence of development of heart failure. And trastuzumab is really a HER2 receptor blocker. And how it works is binds to neuregulin. Neuregulin is important for normal HER2 receptor function. So trastuzumab binds to neuregulin and prevents HER2 receptor function, which leads to cell death. Immune checkpoint inhibitors are something that are becoming increasingly used now because there's a lot of research and they have been shown to be quite helpful in a lot of advanced stages of cardiomyopathy. Unfortunately, one of their side effects is also causing various cardiac toxicities and most importantly, myocarditis. So in a registry study of 35 patients with checkpoint inhibitor myocarditis, they found that the incidence was 1%. The incidence of development of checkpoint inhibitor myocarditis was 1%. It was increased with dual inhibition. Median presentation was about 1 month. And why this is important is because there is a very high association with MACE events. So about half the patients had MACE events: death, cardiogenic shock, arrest, and complete heart block. And a troponin T of greater than 1.5 is predictive of MACE. You can see that most patients had an abnormal ECG, abnormal troponin, abnormal NT-proBNP. Interestingly, about half the patients presented with a normal EF. Checkpoint inhibitor myocarditis is notoriously associated with bradyarrhythmias as well as tachyarrhythmias, and these can be really difficult to manage. Other toxins that are important are cocaine and methamphetamines. Both are directly toxic to the myocardium. So cocaine, in addition to provoking coronary artery vasospasm, can also cause increased reuptake. Can also cause reduced reuptake of catecholamines. And these vasoactive effects of cocaine are further complicated by enhanced platelet aggregation, anticardiolipid antibody formation, and basically abnormalities in thrombosis and coagulation. There are reports of reversibility of cardiac function after cessation of drug use. And this is something that is kind of controversial, but really there's no strong data suggesting that beta blockers should be avoided. It is felt that beta blockers with alpha blocking properties such as carvedilol might not have significant unopposed alpha agonism with cocaine and might be more beneficial in these patients. Methamphetamines are associated with a significant risk of cardiomyopathy, and this can be reversible. LGE is helpful to identify the magnitude of fibrosis and likelihood of recovery in these patients. And again, importantly, you want to advise your patients to remain abstinent from these toxins. Another important cause are infectious cardiomyopathies. These can be viral, bacterial, protozoal, spirochetal, HIV as well. So these are things that you want to evaluate patients for when you're doing your initial workup. myocarditis is most commonly associated with viral etiology. Myocarditis can be from other causes, but the reason I put it under infectious is because the most common etiology is viral. And again, this can be a direct viral injury as well as indirect effects also of the viral infection. Most common viruses associated with myocarditis are Coxsackie B as well as other enteroviruses. Clinical presentations, essentially can be acute heart failure or chronic heart failure. You have to keep a low threshold for deterioration in these patients, especially if they're presenting with acute heart failure. There are diagnostic criteria which can alert you as to the etiology of the cardiomyopathy being myocarditis, particularly if there's associated with AV blocks, bundle branch blocks, ventricular arrhythmias as well. You'll see elevated myocardial injury markers like troponin. There can be abnormalities you see on CMR as well, edema or LGE, and then tissue characterization by CMR can be helpful as well. There are three phases essentially in development of myocarditis by viruses. Phase one is myocardial damage by viral infection and replication. And then innate immunity, which really leads to the development of the LV dysfunction that you see. And then chronic cardiac remodeling can occur over time and lead to dilated cardiomyopathy. Treatment essentially is following the current heart failure guidelines. Patients should refrain from competitive athletics for at least 3 to 6 months because myocarditis has been shown to be associated with sudden cardiac death. There have been some high profile cases of basketball players who had syncope or sudden death while playing. Some of these patients, if they have a Fulman presentation, may require advanced cardiac support, such as temporary or even permanent MCS or heart transplant. Immunosuppressive therapy, including steroids and CNIs and other agents, is indicated for the treatment of acute dilated cardiomyopathy caused by giant cell myocarditis. And in the absence of ventricular arrhythmias or syncope, an ICD is not indicated acutely for these patients, since there may be recovery of ejection fraction over time. Other causes of dilated cardiomyopathy are inflammatory, infiltrative, or autoimmune diseases. These can be hypersensitivity myocarditis or Loeffler's endocarditis. Infiltrative diseases like hemosiderosis or sarcoidosis. Sarcoidosis is an important etiology, and you should have a suspicion if there are associated bradyarrhythmias or chest X-ray findings or other systemic findings. Vasculitis can be associated, and connective tissue diseases like lupus, scleroderma, dermatomyositis can be associated with cardiomyopathy and even myocarditis. Metabolic and endocrine diseases can also be associated with dilated cardiomyopathy. Important ones are thyroid diseases and growth hormone diseases. Certain nutritional deficiencies like thiamine, carnitine, selenium are rare causes. Obesity cardiomyopathy is an important cause that has emerged as an important risk factor for development of non-ischemic cardiomyopathy. And this is basically showing the mechanism for how obesity leads to multiple changes that over time lead to the development of cardiomyopathy, important ones being increased circulating blood volume and development of sleep apnea and hyperventilation syndrome. This over time leads to hypoxia, acidosis, PH, RV enlargement and hypertrophy, and RV failure. The presence of increased circulating blood volume, as well as neurohormonal activation and metabolic alterations in obesity, lead to LV dilatation, wall stress, hypertrophy, systolic and diastolic dysfunction, and then LV failure. And weight loss, either through lifestyle modifications or bariatric surgery, is recommended and can reverse the cardiomyopathy. Other important causes are peripartum, stress-induced, and tachycardia-induced. I'm going to go a little quickly over here because I know we're reaching the end of the hour. Peripartum, or now the broader term, is really pregnancy associated, but peripartum cardiomyopathy is classically LV systolic dysfunction, LVRV systolic dysfunction presenting during the last month of pregnancy or in the first 5 months postpartum. Pregnancy associated is cardiomyopathy that can be outside of these months as well. Risk factors for peripartum cardiomyopathy are increasing age, multifetal pregnancies. Importantly, African Americans have a much higher risk of developing peripartum cardiomyopathy. Other risk factors are hypertension, preeclampsia, gestational diabetes. The mechanism is not clear, but it is felt to have both inflammatory and genetic components. The inflammatory component is felt to be an autoimmune mechanism, and there is thought to be an association of prolactin causing an autoimmune response in the myocytes leading to damage. Recovery of LV function has been reported in a majority of cases within 6 months or so. Subsequent pregnancy in these patients is associated with a significant risk of recurrence, including low EF and recurrence of heart failure. Pregnant women with peripartum cardiomyopathy should be referred to a center with experience with this condition. Multidisciplinary care is required with a high-risk OB team. Close monitoring before, during, and after delivery is recommended. Medication management is a little tricky in these patients because of the associated risk to the fetus. Diuretic agents should be used when appropriate to treat volume overload, but they should be used sparingly to avoid reductions in fetal blood flow. Can lead to oligohydramnios over time. ACE inhibitors, ARBs are contraindicated. Hydralazine can be used, nitrates can be used. The use of beta blockers can cause slowing of the fetal heart rate, blood sugar, and blood pressure, but this is from animal studies. There aren't really any studies with any of these agents in women, especially, in humans, but generally it is thought that the benefits outweigh the risks. Most of these drugs are category C, except for ACE inhibitors and ARBs, which are contraindicated. Prompt delivery is recommended if patients are unstable. Vaginal delivery is preferred in general, but C-section is reserved only for patients who are critically ill or if they need it for other obstetric indications. Early delivery may not be required if the mother and fetus are stable. There is a higher risk of fetal complications associated with peripartum cardiomyopathy, including IUGR and fetal loss. Breastfeeding is controversial, and again, ACE inhibitors and ARBs should not be used in breastfeeding women. It's reasonable to allow about 6 months or so of optimal medical therapy to allow for myocardial recovery before deciding on placement of ICD and CRT. Other therapeutic options which are really controversial is anticoagulation. It is recommended in a certain select group of women with peripartum cardiomyopathy, particularly if they have a very reduced EF. The use of bromocriptine is not really recommended. There were a few small studies that showed it could be possibly beneficial, but is not widely used or indicated or recommended. Duration of heart failure therapy recommended to be given indefinitely if the EF does not normalize. If it does normalize, it's controversial on whether heart failure therapy should be stopped. Family planning is recommended again because of the high risk of recurrence of peripartum cardiomyopathy, particularly if the EF does not normalize. Stress-induced or Takotsubo is again something that's infrequently seen, but I'm sure all of you have come across at least one case of this. It's an acute transient LV dysfunction triggered by profound emotional or physical stressors. It is associated with the distinctive pattern of apical ballooning, though a reverse Takotsubo cardiomyopathy pattern can also be seen where there is preserved function of the apex but reduced function at the bases. There's a predilection in postmenopausal women, and 96% of cases are women who are more than 50. Mechanisms not well understood again, but thought to be related to a surge of catecholamines. The ventricular apex is more responsive to this because of increased beta-2 receptor density. Other theories include microvascular vasospasm, fatty acid metabolism impairment, transient LVOT obstruction, catecholamine associated with myocardial stunning, and direct myocyte injury. You can see ECG changes, sometimes even ST elevations in these patients, and troponin elevation. And this is, as the names, as it's included in the definition, is transient and reversible. The duration of heart failure therapy is not really well defined. Tachycardia induces another important cause. This is generally reversible, can be due to atrial arrhythmias, ventricular arrhythmias, PVCs as well, and long-standing RE pacing. It's The duration of tachycardia is not well defined, and how fast the rate has to be is also not well defined, but generally thought to be a rate of greater than 100 beats per minute. Chronic and rapid atrial and ventricular pacing can result in neurohormonal activation characterized by reduced serum sodium, activation of RAS, and increase in plasma atrial natriuretic peptides, aldosterone, norepinephrine, and epinephrine. And interestingly, tachycardia-induced cardiomyopathy are the models that were used initially in studying heart failure. So the way heart failure was really studied initially was inducing tachycardia by pacing in mice and causing heart failure. This over time leads to myocardial energy depletion, decreased energy utilization, ischemia, and abnormal calcium handling. It's very important to maintain sinus rhythm or control the ventricular rate. Is critical to the treatment of these patients, and this can be reversible. CRT can be used in select cases like patients who have RV pacing-induced cardiomyopathy or rapid atrial arrhythmias, where an AV node ablation along with CRT implant can be done. So this is a kind of complicated flowchart of diagnostic evaluation in patients with unexplained cardiomyopathy, but just want to point out the highlights. The first step in somebody with an unexplained EF of less than 50%, you want to take a detailed history, assess for the causes of cardiomyopathy we talked about above, social history, family history should be obtained, exposure to toxins, substance abuse, pregnancy, etc. Initial workup in all patients should include CBC with differential, metabolic panel, thyroid, liver, chest X-ray, echo, ECG, HIV, and iron studies. Then ischemic workup. If there are risk factors or signs or symptoms of ischemic disease, you might want to pursue an invasive coronary angiography, otherwise a non-invasive such as stress test or CMR. If patients have acute decompensation or heart blocks, arrhythmias, consider myocarditis, and an endomyocardial biopsy can be helpful for the diagnosis for this. Further testing is based on clinical suspicion. So assess for rheumatological diseases, genetic testing if you have suspicion from familial or hereditary cardiomyopathy, amyloidosis, substance abuse, infections, endocrine diseases. Again, based on clinical suspicion, and MRI can be helpful. CT scan of other organs if you suspect systemic diseases, and endomyocardial biopsy in certain other cases like amyloidosis, Loeffler's, hemochromatosis, sarcoidosis. Coming to the management really briefly.
I'm so sorry, Dr. Singhvi. I think that might be all we have time for today, okay, unfortunately. Yeah. I know Dr. Citron is on the call as well.
Okay, sure.
But we can also upload the slides as well, if that would work.
Yeah, sure. Sorry, that was just I started about 5-7 minutes late or so, but this was really my last slide anyway, because the management, as you know, is management for heart failure with medical therapy and devices as indicated based on guidelines.
Great. Thank you so much for this. It was really, really useful.